Colleague, this session. Sorry for starting late. We were just setting up. So today we have two case discussions, and then we have Professor Moyes who's joining us. Dr. Swale will start the first presentation. Dr. Swale is one of our residents, our senior residents, soon to graduate from OBS and Gynae. Karibu sana.
Thank you very much, Dr. Rosa Chumwe. Good afternoon, ladies and gentlemen. I'm Dr. Rukia Swale Gangombe, a resident in Obstetrics and Gynecology, Department of Health Sciences at the University of Nairobi, Kenya. And I have the honor to present to you a case that we followed up due to Rhesus alloimmunisation in pregnancy at the Kenyatta National Hospital. The management of this patient was headed by Dr. Rosa Chumwe and Dr. Icole Adungo, both of whom are maternal fetal specialists at the Kenyatta National Hospital. I have no conflict of interest to declare for this presentation, and the patient provided us with written consent to publish and also present this case in academic and professional fora. So the patient's name is MMS. She's a 28-year-old para 2+2 gravida 5, who presented to us with a well-dated pregnancy at 20 weeks gestation. She's Rhesus D negative with no living child at the time of presentation and had been referred to us for maternal fetal care due to Rhesus alloimmunization following a positive indirect Coombs test that had been done at 15 weeks of gestation. At presentation, her main concern was fear of pregnancy loss in view of the fact that she had no living child. She was able to perceive good fetal movement, and she did not have any other obstetric symptoms, including low abdominal pain, drainage of liquor, pervaginal bleeding, pervaginal discharge, or symptoms of preeclampsia. The identifiable risk factors of alloimmunization in this patient included previous history of multiple admissions, where she required multiple blood transfusion in early childhood. Of note is that she did not receive prophylactic anti-D in her first pregnancy, and her husband's blood type was B Rhesus positive. For her antenatal history, she reported that this was a planned pregnancy but had not undergone preconception care. By the time she was presenting to us, she had had 2 antenatal contacts at the peripheral facility from where she had been referred to. Her first contact was at 8 weeks of gestation. She had been normotensive and had demonstrated normal antenatal weight gain with a body mass index of 24.8. She was also low risk for venous thromboembolism based on the Royal College of Obstetricians and Gynecologists scoring system. For her antenatal profile, she had a normal hemoglobin level of 12.6 grams per deciliter. Her blood group was O Rhesus negative, and a confirmatory DU test that had been done at the peripheral facility was negative. The other parameters of her antenatal profile were otherwise normal. So for her past obstetric history, of note is that she conceived all her babies from the same male partner. Her first pregnancy was in 2017, where she delivered at term via emergency cesarean section due to non-reassuring fetal status in twin gestation. She did not know the baby's birth weights, but reported that both of them had died on day 1 of life due to hydrops fetalis. Unfortunately, she did not know the baby's blood groups, and she declined any history of sensitizing events, including invasive prenatal care, abdominal trauma, or early pregnancy bleeding. And as mentioned earlier, there was no history of prophylactic anti-D in this pregnancy. There was also no antibody testing that had been done in the first pregnancy. So her second pregnancy was in 2020, where she had a pregnancy loss at 24 weeks. She reported that this was preceded by sudden onset of labor-like pain and pervaginal bleeding, and the total duration of labor was 8 hours. Again, she did not know the baby's blood group in this case, and an indirect Coombs test had not been done. Her third pregnancy was in 2021, where she had a pregnancy loss at 1 month. And at this point, she had not commenced her antenatal care. And she reported that the miscarriage was medically managed. Her fourth pregnancy was in 2022, where she delivered via cesarean section at term due to hydrops fetalis in a previous SCAR patient. The baby's birth weight was 2,700 grams. And again, the baby reportedly succumbed immediately after birth. The baby's blood group was also unknown. So other than the previous history of multiple blood transfusion and 2 cesarean sections, her past medical, surgical, and family social history were non-contributory. And on examination, she was vitally stable with a fan and tail scar and a fundal height that corresponded to 20 weeks gestation. The baby's fetal heart rate was normal at 136 to 142 via Doppler, and her pelvic exam and the rest of her systemic examination was normal. So with a diagnosis of para2+2 gravida 5 with bad obstetric history due to Rhesus D alloimmunization and 2 previous cesarean scars at 20 weeks, we did an anomaly scan at the first contact in our facility, which showed normal fetal anatomy with no features of hydrops fetalis. The placenta was fundoposterior with normal Doppler indices and adequate amniotic fluid. So in view of the Rhesus D alloimmunization, we started her on oral methylprednisolone 4 milligrams twice a day. We also continued the iron, folic acid, and calcium supplementation. And according to the American College of Obstetricians and Gynecologists, serial antibody titer monitoring for fetal for determination of fetal status is not recommended in Rhesus alloimmunized mothers with previously affected fetuses or neonates. So in this case, we did not monitor the antibody titers. For these patients, weekly monitoring of the mid-cerebral artery peak systolic velocity is recommended. But in our case, we were unable to do that due to financial constraints. So the MCA PSV was monitored every 2 weeks. We also monitored the baby's growth charts from 24 weeks. And maternal serum cell-free fetal DNA was not doable due to unavailability of this test in our setup. So throughout our antenatal follow-up from 20 weeks, the fetal anatomy as well as the mid-cerebral artery peak systolic velocity remained normal until 33 weeks of gestation, where the MCA PSV was 72 centimeters per second, and this was equivalent to 1.556 multiples of median. So as we all know, an MCA PSV above 1.5 is indicative of fetal anemia. So in view of this, the patient was admitted for codosynthesis. The codosynthesis sample revealed severe anemia with a HB of 6.6 grams per deciliter. The hematocrit was reduced at 20%. We also had macrocytosis of 134 and hyperchromasia in view of an elevated mean corpuscular hemoglobin of 44 and spherocytosis on the blood smear. The red cell distribution width was also elevated at 26.3%. The fetal blood group was B, Rhesus positive. So this picture is in keeping with immune hemolytic anemia, and it's at this point that the diagnosis of hemolytic disease of the fetus was made. So we decided to do the first session of intrauterine transfusion, which was at 33 weeks. And we transfused the fetus with 50 mils of type O, Rhesus negative, cytomegalovirus negative, leukodepleted, irradiated packed cells that were cross-matched against the maternal blood. The immediate post-intrauterine transfusion fetal total blood count showed marked improvement in the parameters, where we had an increase in the hemoglobin level from 6.6 to 10.1 grams per deciliter. The hematocrit increased from 20 to 30%, and the red cell indices normalized. At the same time, we started her on antenatal corticosteroids for fetal lung maturation in preparation for delivery at 34 weeks. 3 days following the intrauterine transfusion, a repeat mid-cerebral artery peak systolic velocity that we performed with 0 degrees angle of insonation was normal at 42.5 centimeters per second. Again, her daily non-stress tests remained reactive, and the fetal kick charts were adequate. So as we were planning to deliver her at 34 weeks of gestation, we repeated an MCA PSV at 34 weeks, which was quite elevated, as you can appreciate from the diagram. it was at 87.13 centimeters per second. And as majority of us will be familiar with, normally the MCA PSV should not be double the gestation. So this patient was at 34 weeks at this point, which means her MCA PSV should not have been above 68. But here we were with an MCA PSV of 87.13. And on keying in the MCA PSV value on the maternal fetal foundation calculator for fetal anemia, it was giving us an estimated hemoglobin level of 5.3, which is in keeping with severe anemia. So a decision to do the second session of intrauterine transfusion was made, and we transfused the fetus with 80 mL of O negative blood. So I prepared a short video to show you how we did the intrauterine transfusion. But in a nutshell, intrauterine transfusion is done under ultrasound guidance. It involves placement of the patient in supine position, followed by cleaning and draping of the abdomen. And then after that, we do an ultrasound to confirm the placentation, as well as to identify the umbilical vein. Then that is followed by administration of local anesthesia and incision on the patient's skin to allow for insertion of the intrauterine transfusion needle. Thereafter, the intrauterine transfusion needle is inserted into the umbilical vein under ultrasound guidance, and transfusion takes place. So let's watch the video to appreciate the same. Okay. So 24 hours following the second session of intrauterine transfusion, the patient was delivered via elective cesarean section with the neonatology team present at birth. We delivered a live male infant with an APGAR score of 18-1, 9-5, 9-10, and a birth weight of 2,650 grams. Delayed cord clamping was done, as well as the cord was also triple clamped to allow for cord blood sampling. The neonate was immediately admitted to the newborn unit for exchange transfusion and further management. The estimated blood loss at delivery was 500 mL, and the postnatal period was uneventful. So as I come to the end of my presentation, I'd like to acknowledge the efforts of Dr. Kunjira Murai, an interventional radiologist at the Kenyatta National Hospital, who assisted us during the intrauterine transfusion. Dr. Fatuma Sharif, who is a resident at the Department of Obstetrics and Gynecology, for performing the cesarean section. Dr. Christine Manyasi, who is present here today, she was the primary neonatologist for this patient. We would also like to appreciate the MPSHA Hospital Blood Transfusion Unit team for screening and irradiating the blood. We also want to send our appreciation to the Kenyatta National Hospital Transfusion Unit team for working closely with us, as well as the MPSHA Blood Transfusion Unit team, and availing the blood to us whenever we needed it. And last but not least, we would like to really appreciate the O Negative Foundation of Kenya for mobilizing blood donors for our patient. With that said, I'd like to thank you all for your attention, and I'd like to welcome my colleague, Dr. Victoria Jebet, to give us the neonatology management. Thank you.
Thank you, Dr. Rukia. My name is Dr. Victoria Chabet, and I'm a resident in pediatrics and child health in the University of Nairobi. And I'm honored and pleased to be doing this presentation of the baby on behalf of the newborn unit under Kenyatta National Hospital. My chief supervisors for this case presentation is Dr. Christine Manyasi, who was the lead neonatologist, and Dr. Jalemba Aluvala, who was the consultant on call at the time where we received this baby. So once again, I'll repeat the biodata. So we received baby of MMS, who was male in gender and was born on the 18th of October. And residence is within Nairobi in Makadara, Nairobi County, and they were born in Kenyatta National Hospital. Just to add on to the birth history from what Dr. Rukia had told us, the baby was born at 8:57 a.m. at the maternity theater, and it was via elective cesarean section, and it was at 34 weeks and 1 day gestation, and it was due to the Rhesus alloimmunisation with multiple pregnancy losses. So the baby cried immediately, and there was delayed cord clamping that was practiced. This is very important, as this was one of our immediate delivery room intervention for this patient. It was a male live infant whose birth weight was recorded as 2650 grams. And we had a good APGAR score of 18-1, 9-5, and 9-10. Immediately, the baby was delivered and we cut the cord. We wrapped the baby in a plastic paper wrap, as it is required in all our preterm babies. And we immediately put the patient under radiant warmer, all in an attempt to prevent immediate hypothermia that worsens the prognosis of our preterm babies. So we did our physical examination, and general examination picked immediate marked pallor. There was marked jaundice as well. There was no cyanosis, no dehydration, no edema that we picked clinically. The skin was intact. Bedside random blood sugar was at 3.6 millimoles per liter within the normal range. And our Ballard score was at 35 weeks. And we do Ballard score just to estimate the physical and the neurophysical development that we can be able to quickly assess on the newborn baby. For the airway and breathing examination, there was a weak cry initially. However, we did not pick any stridor and there were normal breath sounds heard. However, there was audible grunting as we continued with the examination with some nasal flaring and also severe chest wall indrawing and quite marked retractions, both xiphoid and intercostal. Together with this, we had increased respiratory rate at 54 per minute, and our saturations were ranging from 87 to 90. So with this, we scored our patient an 8/10, and this is through the Silverman-Anderson score that normally helps us deliberate on the way of managing our respiratory distress in newborns. On the circulation examination, our cap refill time was immediate, less than 2 seconds. We had good peripheral pulses that were present and they were synchronous. We were able to assess the right radio femoral pulses and they were quite synchronous. Our normal, on the heart sounds, we had S1, S2. However, we were able to pick a loud murmur that was systolic in nature at around the intercostal space on the left upper sternal border. We did our pre-ductal and post-ductal saturations, and they were unremarkable. They were between 91 and 92%. On the pulse rate, it was good at 178 per minute, and our pressures initially were within normal for age at 47 diastolic out of 27 systolic millimeter of mercury. On the neurological examination, there was dull mentation. The newborn was not very active at first. However, the fontanelle and the head shape were normal. We had a head circumference of about 33 centimeters, in keeping with about 90th percentile on the growth chart for age. There was normal tone. However, we picked that there was absent reflexes, that is rooting and suck, and also the grasp reflexes, both plantar and palmar, were decreased. Moral reflexes were present, which we were happy about, in keeping in mind with the severe jaundice that we had picked clinically. On the abdominal examination, on inspection, the umbilicus appeared normal. However, we caught some mild distension, and on palpation, we were able to pick a hepatomegaly of 6 centimeters below costal margin and a splenomegaly of about 4 centimeters. However, we were unable to elicit any fluid thrill or shifting dullness, and there was a normal anal opening. On the genitalia, normal male genitalia was observed. On the rest of the examination, there was normal musculoskeletal examination, including the hips. The spine had a normal curve, the palate, the ears, and the eyes. We picked normal anatomical findings. So at this point, we came up with a primary diagnosis of a late preterm with respiratory distress syndrome, severe anemia, neonatal jaundice, all due to the hemolytic disease of the newborn. Then we also made a secondary diagnosis of risk of sepsis, especially in keeping with the respiratory distress that we had picked. And with the added systolic murmurs, we made an impression of a possible patent ductus arteriosus. So over here, you will see some of the delivery room interventions that we made. As Dr. Rukia said, the team was able to do triple clamping of the cord. And with this, it allowed us quite a good length of the cord. It was about 10 centimeters, where we were able to take our cord blood samples. And this included the arterial and venous blood gases, a complete blood count, ferritin levels, the liver function tests, the serum, total bilirubins, and also the extended biochemistry panel. And also at this point, we did one for DCT and blood group. I will share the results as I continue with the presentation. So over here next is just a video that should help us appreciate how we were able to intervene with the respiratory distress that we picked for the baby. I don't know if we are able to see. Let me try from my end IT. So what we are doing over here, we were trying to connect our newborn baby to the CPAP, bubble CPAP. And this is important as the respiratory examination proved that the patient was having respiratory distress. And I hope as we continue, you will be able to see some of the lower chest the video, you can see Dr. Manyasi was now detaching the cord that we had on so as to start our sample collection. So the next slide, the picture that we can see, this was now after we had stabilized our patient. Our nasal CPAP was ongoing. We had done the necessary setting, and that was an FiO2 of 50%, a PEEP of 6, with an oxygen flow rate of 4 liters per minute. And with that, we were able to achieve our oxygen delivery target of 90 to 95%. If I'm to closely zoom in, I'm able to see what at this point we achieved 95% of SpO2 reading. So from this point, we were confident to transfer our patient to the newborn unit. We had already made prior arrangements. We had a transport incubator that was pre-warmed. And our plan now for transfer was to continue with further management that would be surfactant administration, insertion of an umbilical vein catheter, exchange transfusion, and further imaging of the patient. So once we landed to the newborn unit, we went to our NICU, where we normally have our most critically ill patients for observation. We had done family-centered care down at the maternity theater. We involved also the father. They had given us consent. And what family-centered care is all about, especially at the newborn unit, is where we want to walk the journey of all the patients who are brought in by their parents in terms of the management. So the parents were aware that we are going to do respiratory support for their baby, that we were going to give some blood products and possible mechanical ventilation. So surfactant was administered and the patient was intubated, as we can see on the right side. And during these interventions, the baby was noted to have some seizures. And with a keen eye, you would note that the patient is having a bit of feasting. So we noted it as focal tonic seizures that the baby was having. So exchange transfusion was done after the UVC insertion, and we did a double volume exchange transfusion, and we calculated our blood volume at a rate of 160 mils per kg. And this was done within the first 7 hours, at the 7th hour of life. So we still used the same blood that Dr. Rukia had mentioned, and it was packed red cells, blood group O negative, that was irradiated and leukoreduced. So midway transfusion, we gave the patient 10% calcium gluconate. Then I just put these numbers here to show us the pre-transfusion total bilirubin levels, and we can appreciate that they were a bit high at 236.2, and it was more of an indirect hyperbilirubinemia. And post-transfusion, the rate had come down to 194. So the rest of the treatment plan was to start intensive phototherapy, which was done. And we were targeting an irradiance of 25 to 30 so as to have the best outcome for our patient. We did our daily IV fluid recommendations as per our protocol. Antibiotics were also given. And also we loaded with caffeine citrate because during the seizures, the respiratory distress, we also picked on some apneic events. Essential newborn care was also observed. And importantly, an intravenous immunoglobulin was prescribed at a rate of 0.5 grams per kg, and it was given 12-hourly for a total of 7 days. And because of the seizures, the patient was loaded with phenobarbital, and also a daily maintenance dose was given. So I captured some of the investigations that were done at admission. And with this slide, I'd like us to appreciate our cord blood gas analysis. Remember, we did both arterial and venous samples. So in newborns, both in support of ACOG and our American Academy of Pediatrics, it is recommended to do immediate cord blood gases, especially in high-risk deliveries. But even practice is coming such that all newborn babies require this blood gas analysis. The arterial analysis is very important because it will help us understand more about the fetal circulation, while the venous blood gas will help us understand better what is happening within the placental metabolism. So as we can see with this, for both pictures, we had a similar picture of primarily respiratory acidosis with a secondary metabolic acidosis. So in this case, I'll be biased and looked a little bit on the arterial one, where we'll see we had a severe pH of 7.165. And even in keeping with the normal picture, normally the cord blood gas is normally slightly acidic, around 7.24, 7.27, but here we can see it was a bit on the lower side. There was also the hypercarbia, and also we were concerned about the lactic acidosis. So this, in keeping in mind, is what necessitated our immediate mechanical ventilation once the baby reached upstairs. And also we can see the low HB of 8.2. So an echo was done by the cardiologist at the 5 hours of life, and it showed the features of a patent foramen ovale and a PDA, which was bidirectional in flow. And this was in keeping with the transitional physiology in a 5-hour-old neonate. Other than that, there was no effusion, there was good left ventricular function, and also the ejection fraction was at 83%. We did an X-ray, as you can see on the babygram on that day 1 of life. And from this, just to eyeball, I will just point your attention to the lung fields. The lung fields appeared normal at first. The cardiac silhouette was within the normal range. But now with an eye of faith, if you look at around the soft tissue, I hope we should be able to appreciate some tissue edema. Then the complete blood count was essentially unremarkable on the white blood cell count. However, the HB was reported still at 8.8, which was low. The DCT that we did this time round with the cord blood showed a DCT being negative, and the blood group, if you can note, was reported as O negative. Remember, pre-transfusion, the baby's blood group was B Rhesus positive. So with this result, we had to be aware that it was as a result of the donor blood that was in the patient's circulation. Okay. Yes, other than that, we can still see on the LFTs that our bilirubin levels were high at 236, and I had already explained on that. This was pre-transfusion. So quickly through the progression in the ward, on the second day of life of the patient, we were still mechanically ventilated and we were using SIPPV mode. However, we were happy because there was resolved respiratory acidosis. Problem for the day was we started noting hypotension in this patient, and the cardiologist came in and they did a bedside echo, which showed that the PDA was now closing, but still we had normal pulmonary pressures and good left ventricular function. So at this point, they suggested that we transfuse because the HB was still low post exchange transfusion. So we transfused at 20 mils per kg and continue to monitor the BP trends. And the plan was to start the patient on inotropic support if the hypertension persisted. An abdominal ultrasound was also done on the second day, and it showed some features of ascites and also the hepatosplenomegaly that we had caught clinically on examination. So on the third to fifth day, we were still on mechanical ventilation. Luckily, after the transfusion, the hypotension resolved. The post-transfusion HB came up slightly to 9.1 grams per deciliter. However, we were concerned around the third, fourth day. We started noting thrombocytopenia, and our CRP was trending upwards. As we can see from the projection, at the time of admission, it was less than 2. After 1 day, it was 9, but now by the time it was getting to the 5th day, it was going upwards of 106. The culture results that we had done, and we had done 2, no growth was obtained. So at this point, the management plan changed, and it was now to switch to second-line antibiotics. And according to our newborn protocols, is piperacillin, tazobactam, and amikacin. And the rationale behind this was the persistent respiratory distress. We are still on higher settings on SIPPV, and also we continued with intensive phototherapy. So at this point, unfortunately, the patient extubated around day 7. We tried transitioning them to CPAP, but the patient failed because of the increased work of breathing. So we reintubated the baby. And now the post-intubation chest x-rays we can see on the first image on our left shows some right-sided apical and a bit on the mid-lobar zone consolidation. And with this now, we added the diagnosis of neonatal pneumonia. So we continued with our second-line antibiotics. Then after 3 days, we can see the X-ray on our right. The consolidation had resolved. So we were happy with that. So after that, we were able to successfully extubate the patient on day 12 of life, transitioned to nasal CPAP. We completed our antibiotics. We, after the second transfusion, our HB rose up to 15.8, and even our bilirubin levels had gone down to 133, and that was below the phototherapy threshold according to nomogram C, if we check on our nomogram charts. So supportive management continued, and in this particular case, we were really aggressive with the chest physiotherapy. So we were able to transition again from CPAP to oxygen therapy via nasal prongs, and a repeat echo that was done through our cardiology reviews now at this time showed there was no PDA and we still had normal pulmonary pressures. So the point of excitement for us is when we were able to wean off the patient off oxygen on day 29 of life, and they were able to sustain themselves with a saturation of 94 to 99% on room air, no distress at all. Occupational therapy now at this point became a little bit aggressive because in pediatrics, we love it when our babies are able to latch and suck. So the occupational therapist helped us a lot with the oropharyngeal reflex so as to stimulate the suck and swallow. So this is just a caption of the investigations that we did towards the end of our treatment. And just a quick summary of it, we can see the HB stabilized 12.1. Even the RBC indices were now within the normal ranges, which is a different picture from what Dr. Rukia had seen, they had seen in utero. And also our bilirubin levels had normalized, they had gone down to 12.81. So at this point, we were happy. So we made a plan to discharge this baby, and they were discharged on day 33 of life, and their discharge weight was at 29.15 grams. We were happy because we had gained some 300 plus grams, and they were discharged while breastfeeding, but we still encourage the mother to do expressed breast milk, top up by cup so as to catch up with the weight, and also supplements that we normally give in all our preterm babies, and this include iron, folate, vitamin D, and some multivitamins. So we did follow up for this patient, and we booked them under our neonatal outpatient clinic. And in this clinic, they're normally seen by our consultant neonatologists and our neonatology fellows. And when they came back for review, there was good weight gain reported at 33.15 grams. A repeat of a blood group was done, and this time now it reflected the baby's own blood group, Rhesus B positive. And the patient was really compliant to supplements, and the next review would be actually sometime this week. Other follow-ups are ongoing, including hearing test, assessment at the ENT clinic, and importantly, our vaccine schedule as per KEPI schedule. So I just put this photo here to appreciate the good work. If you can remember where the baby came from on day 1 in NICU, we were all tubed up, lots of wires everywhere. And by the 30th day, as we can see, this was just immediately after feeding, we decided to take a photo of them. And you can see baby was quietly sleeping and our saturations were good. At this point, it was at 94%. So in summary, I have presented baby of MMS. A male preterm was born at 34 weeks via elective cesarean section to a mother with Rhesus alloimmunization, and they had received in utero blood transfusion. So they were managed for hemolytic disease of the newborn, severe anemia, hyperbilirubinemia, neonatal sepsis, and respiratory distress syndrome. So what did we do? Exchange transfusion was done, IVIG was given, blood products transfusion, intensive phototherapy, respiratory support, and antimicrobial therapy. So the patient became stable and discharged home on day 33 of life, and they're currently home, growing and thriving, and follow-up is ongoing. So to achieve this, there was multidisciplinary approach. And at this point, I would like to recognize the efforts of everyone, including our lead neonatologist, Dr. Manyasi, the other pediatric neonatologists, their general pediatricians who work in the unit, our cardiologists, the neonatology fellows, the hematology team, nutritionists, the nursing team, and I can see our matron here, the occupational therapy team, the chest physiotherapist, the unit counselors, which are very important in our pediatric cases, and also the Kenyatta National Hospital blood transfusion unit. So this is just a picture that Dr. Chemwe is in it, the far left. Then there's Dr. Manyasi, who's on the third right. Then there's Dr. Weru, who's one of the neonatology fellows on the second left. And the rest of the people on the picture are my fellow pediatric residents. And behind the doors is the bigger team that made this possible. And this photo was taken on the auspicious day when we discharged our patient, and we were very happy. And as a team, we are hopeful that we'll have many more success stories. So once again, thank you so much for your time. Over to you, Dr. Chemwe.
Thank you very much, Dr. Jebet. And at this point, I would like to appreciate our virtual attendance. We are almost reaching 1,000. So this is very impressive. And we are hoping we are cutting across the country so that as the KNH and the UON, at least we can show if we work as a team, then anything is possible. So we have a few questions, maybe just 5 minutes to address some of the questions, and then we move on to another short presentation before we invite Prof. Moise. So we have some questions that Dr. Rukia and Jebet, you can take up.
Thank you, Dr. Chimwe. So the first question is from an anonymous member who asks why we used the Rhesus negative, the O negative blood for intrauterine transfusion. The reason is because, as we know, O negative blood, O blood type is Rhesus. I mean, is a universal, what do we call it? A universal donor. And for that reason, that's why we picked the O type blood. And then what are the complications of intrauterine transfusion? The one that we experienced during our own sessions was extravasation of the blood from the umbilical vein, and which stopped spontaneously. But and that's why, if you noted from my presentation, the initial session of intrauterine transfusion, we had 50 mils of blood transfused. And then in the second session, we transfused 80 mils. The intention was to actually transfuse 80 mils in the first session, but due to that complication, we had to stop at 50. How do you calculate the amount of blood to be transfused? This is from Dr. Ndungu. The amount of blood to be transfused during intrauterine transfusion is based on a calculator that one can easily find on the perinatology website. It puts into account the donor's hematocrit level and the fetal hematocrit level as well. So we use that, but I'm sure Prof. Moise will shed more light on that. The next question is on a neonatology patient. On the neonatology team. They're asking why, whether we found the birth weight of 2,650 grams to be normal for a 34-year-old.
Thank you so much. Good question on the birth weight. The birth weight of 2,650 for a 34-week preterm is actually on the higher side. So we categorize the patient as a large for gestational age. And actually, because of this, but I will let my senior colleague discuss it, we were debating on whether to categorize our patient as hydropic, because we had signs of soft tissue swelling in the chest X-ray. The abdominal ultrasound showed some features of ascites, and then also we were large for gestational age. So by that classification, I would say in our end, we'd say the patient had hydrops. Yes. Thank you for that. And then there's also a second question on neonatology. Someone had asked something about the seizures. What is the possible reason as to why the patient had seizures, and why did we stop the phenobarbital? So initially with the seizures, our impression was the possible hypoxia that we were having that was also reflected on the blood gas analysis. And we did not abruptly stop the phenobarbital. We continued with maintenance dose actually up to day 9 of life. And we stopped by staggering that or observe any seizures for 7 consecutive days, we stopped the phenobarbital. Somebody is also asking the feeding schedule for the baby from day 2 of life. Yes, sorry, I did not delve into that, but from day 2 of life, from what I can recall, we were still on IV fluids. So at this point, we moved from the 10% dextrose that we normally give on day 1 of life to now our parenteral nutrition. And in this case, in day 2 of life, we use our 0.9% normal saline. We do our electrolytes, including the KCl, and also dextrose for sugar. Yes.
Thank you very much, Dr. Jebet and Dr. Rukia. We have more questions, but in the interest of time, we will keep moving on, and then we will answer some of your questions virtually. Only one mention in terms of financial. This hasn't yet been costed. We are hoping to get it in the NHIF, but this would be in the range of about 30,000 for every IUT that we do. But hopefully we will streamline our system in that way. Now, I would want to welcome our next presenter. We change gears a little bit on hemolytic anemia, not limited to the Rhesus alloimmunization, just for our own understanding before we invite Professor Moyes. Karibu sana, Dr. Manyasi.
Good afternoon, everybody, and thank you for having us. Thank you for attending this forum. We discuss a very pertinent and often emotive diagnosis that I know many of us have encountered. And so just as the presentation comes up, allow me to say two things about this very interesting case that has been presented. Of note is it was a very, let me say, sweet success where many have failed. And it was not an easy task. It took a lot of effort. And behind the scenes were many players who were very kind and facilitated this. So for that, we are grateful. We would like, thank you. We would like that this is replicated many times over, and we need to normalize this. And because of that success, allow me to dampen your spirits a bit with another case that was this time not very successful. And the purpose of presenting this is because of the lessons that we derive. This second case occurred months before the first case we presented. And there were lots of, learning points that I'm glad we learned from, and we did better the second time. And we hopefully get better each time. So the second case I present is that of the second case is that of baby Didi, who was born on the 1st of August at a gestation of 38 weeks, a female infant with a birth weight of 30-45 grams, having scored 7 in 1, 8 in 5, and 8 in 10. Of note is that this baby was delivered at a facility different from the Kenyatta National Hospital. Prior to this delivery, the mother was a 35-year-old para 1+0 lady who unfortunately had lost her first baby. This did not come up until a little later, which was probably one of the first painful lessons from this case. So the mother had lost her first baby from what was believed to have been meconium aspiration, and the baby died in the first day of life. She was otherwise in good health, had no comorbidities. She had gave a history of no infant losses in close family. She was in a non-consanguineous union, although she was not officially married to the father of both babies. Both babies were fathered by the same man. She had had no maternal medication beyond the supplementation we give of iron and folate supplementation. She was blood group O positive. Her serologies were negative, and her HB level had been reported normal. Now, following the events of delivery, we went back and extracted some more information from her. And she reported that in her first pregnancy, she had had reportedly normal ultrasounds, but these ultrasounds were done by radiology staff, mostly sonographers. She reports a history of extreme malaise. She says she was very tired. towards the end of both pregnancies. And she had raised this concern with her obstetrician, who had reassured her and told her that that is quite a common occurrence and not to worry about it. And on her own account, she says that the first baby was extremely jaundiced and looked very pale at birth. She said this after seeing the condition of the second baby at birth. And of note is that the baby was born through meconium. After that, she did not have much detail, except that the baby had died in nursery, having had severe breathing difficulties. No autopsy was done at this point. Later, she had seen a maternal fetal specialist, but this was in retrospect. They had done some evaluation, but the conclusion had been to just wait and have a better follow-up in the next pregnancy. Unfortunately, that did not happen in the second pregnancy either. So this lady was delivered at 38 weeks, as I had said, after a seemingly uneventful pregnancy. It was reported she had had an ultrasound 3 days prior to this delivery that was reported as normal. And so she was scheduled for an elective cesarean section, basically for a previous scar. But at extraction, and of note, I was present in this delivery, but that was my first contact in the delivery room because I needed to step in for a colleague. At extraction, the baby was female, quite floppy, markedly pale, but there was no visible jaundice at the time, and there was meconium noted at extraction. Baby responded to suction, stimulation, and oxygen. So at that point, I decided to take samples of cord blood for gas and several other evaluations, and recommended that in view of the recurrence, we get a placental pathology done. Unfortunately, this did not happen, and that was, I think, one of our painful gaps. So the baby developed rapidly worsening distress that necessitated transfer to NICU and was started on nasal CPAP, received 1 milligram of vitamin K once they got to the neonatal ICU. On further assessment, baby was significantly pale, non-dysmorphic, had no obvious edema, no signs of bleeding, was in marked distress, which improved on initiation of CPAP, had abdominal distension with a hepatomegaly of 7 centimeters below costal margin, but the spleen was not palpable. The cord had normal architecture with 2 arteries and a vein. Had dulmentation, reduced tone, poor reflexes. Cardiovascular system was barely stable. So we've managed of ABO usually don't get this severe, and especially don't start in utero. Most of them, we see them after birth, but all the same, that was a consideration, or other congenital hemolytic anemias, and we sought to investigate that. The other differential in view of the recurrence was neonatal hemochromatosis, gestational alloimmune liver disease. Also entertained a diagnosis of torches, and we sent out samples to investigate. Neonatal alloimmune thrombocytopenia was a consideration that came up along the way. Unfortunately, I was not able to retrieve the full gas panel, but what was notable was the cord pH was 6.9 and 7.1, arterial and venous respectively. There was significant metabolic acidosis, and hemoglobin estimation on the cord blood was 5.7. So initial management for this baby started on fluids. Later, we were actually able to feed the baby. I started on nasal CPAP, to which the baby responded quite well. Empiric antibiotics, pending labs. We did a cardiovascular evaluation, and on echo, baby had poor function and necessitated starting off some medication to support cardiovascular function. We ordered a packed red blood cell transfusion in view of the hemoglobin, and requested for a hematologist review for further workup. Now, within 6 to 12 hours of birth, this baby actually showed marked improvement with stabilization of the breathing. Most vital signs were actually stable, and we were actually able to wean down the CPAP, and feeding was started by that evening because the baby was now awake and hungry, and taken off CPAP within 24 hours. Of note is that by then the baby had not been transfused. The transfusion was still pending because there was no blood available. So blood was got at about 13, 14 hours of age, and they were not able to get O negative leukoreduced blood. So they did group-specific blood cross-matched to the mother's sample. Now, of note is the same night, because this baby had been delivered in the morning, or the same night it was noted that the baby was jaundiced, and by morning was actually significantly jaundiced. And from there on, it was downhill. So had significant jaundice, as I'll show in the labs. There was worsening of the neurological status, and by day 3, now we were experiencing clinical seizures. The organomegaly that was there before worsened, and by the end of the 3rd day, the baby had started bleeding. We were having petechia and ecchymosis. So by the 2nd day, when we saw the rapidly worsening bilirubin levels, we agreed that it was time to do an exchange transfusion, even as we evaluate further. But there was no blood, and that took another painful 20. We controlled the seizures and went on to support the breathing. Unfortunately for this baby, we managed to do the exchange transfusion, albeit late. We tried all other measures, but we did not end up with the success stories. So some of the labs that I would like to go through. The first day of life, you'll notice that our hemoglobin was 5.7. This was done on the cord blood, and the platelet count was 80. The following day, this was after the baby was transfused. The HB had gone up to 15. Platelets remained about the same, but the white cell count had gone up almost tenfold. There was a problem with the processing samples on that afternoon on the repeat. So the hemogram was not repeated, but I'll show the other samples that were run. On the 3rd day, when we were now working to perform the exchange, part of the decision was made because the hemoglobin that had gone up to 15 had come crashing back down to 8, and that's within 24 hours. Platelet had also gone down, although on its own did not meet threshold for transfusion because there was no bleeding, but it was a concern all the same. And it's until 8 p.m. that we managed to get blood to transfuse, to exchange this baby. And by then, the hemoglobin was 7. The white cell counts had shot up. And on this account, antibiotics had actually been switched in as much as that the accused phase reactants were normal, but it was logical that the baby was rather sick. So you can see the pre-exchange levels had significantly deteriorated, and post-exchange a bit of improvement, but by the following day, we still ended up at the same level, but this time with a lot worse platelet counts. Next slide. So the chemistries, you can see from the liver function. So unfortunately, the cord sample we did another sample. So we don't know how high the cord bilirubin was, although the baby was not obviously jaundiced at birth. But by the following morning, the bilirubin was 233, by no means high. And a second level done after 6 hours was 273. And of note is that the liver enzymes were actually not terribly deranged. The synthetic function was fairly well preserved. Even the coagulation, as you'll see on another slide. But going further from that, you can see the rapidly rising bilirubin levels that just kept going up and up despite intensive phototherapy, intravenous immunoglobulin. They did not abate until we did the exchange transfusion. Next slide. So some of the other labs we did on advice from the hematologist were, you can see on the lower slide, LDH was very raised, so that was obvious hemolysis. Haptoglobin very depressed, again consistent with hemolysis. Ferritin levels about double normal. B12 folic acid were considerations the hematologist had, but those were normal. Of note is this baby, eventually we got the blood group and it was B positive, but the DCT was notably negative, even with all the hemolysis that was going on. So that cast doubt on our immune hemolytic diagnosis. Blood culture was negative. Our Torches serology was negative. We were unable to get a reticulocyte percentage done. I don't know what happened to that sample. A PBF requested, unfortunately, also didn't happen. And a salvage specimen, the hematopathologist said that the slide was poorly prepared, so he was not able to deduce much from it. Other investigations done, chest X-ray was normal. Echo showed persistent pulmonary hypertension, which was reasonable based on the condition of the baby with poor contractility, but that improved after medication and the ultrasounds were normal. So this baby, having lost this baby within 72 hours of birth with many unanswered questions, we thought the logical thing to do was to do an autopsy, at least to be better prepared next time. And the pathology reported notably the three things: pallor, bleeding, and jaundice. Okay, which was not different from what we had clinically. The etiology of all this, we didn't quite get to figure out. Liver histopathology. So there was reported distortion of the architectural configuration of the liver, but the hepatocyte morphology was maintained, which sort of went against our suspicion of GALD, gestational alloimmune liver disease, because that usually destroys your hepatocytes quite rapidly. So that cast doubt on our diagnosis of hemochromatosis. Interestingly, there was intrahepatic fibrosis with the mixed cell inflammatory cell infiltration. So that told us something had been happening to this baby before delivery. And it was not just a hit and go at birth, as the ultrasounds had suggested. The other organs just showed basically hemorrhagic congestion that was consistent with our massive hemolysis and fluid distribution. So This is a baby who, to date, we still remain with a lot of unanswered questions. And I would like Prof. Moise's perspective or thoughts on this. We have a mother out there who still looks upon us to find answers so that there's no repeat of the same. But notably, we sat down with the team and audited several gaps that we thought happened. And I highlighted this case because this is probably the occurrence more often than the successes. This is the reality that we live in. So what did we audit about this baby? One, that despite voicing the need that something is wrong and it's happening again, let's please look at the placenta. It did not happen. Yeah, it was macerated. And by the time we went back to retrieve, it had been macerated. We had significantly delayed transfusions due to lack of blood products. All of us who work in KNH know that that's a life we live with. So it's an area that we really need to try and work on. The fact that we delayed giving intravenous immunoglobulin because of needing pre-authorization in view of the cost involved, and probably not very well communicated so that early intervention was sought. But the laboratory was probably the slowest responder in all this, because we had issues ranging from mislabeled samples to slow dispatch of results to, critical samples that the lab does not call and say, hey, I'm looking at a bilirubin that looks like this, and I'm looking at, no, it would literally find its way in the file several hours later before anyone could act on it. And even after we knew we were losing this battle and we took some samples for further analysis, after the baby died, I think most people concluded that this was a lost cause. So the samples were discarded. So what would be our diagnostic considerations for this mother? We know that there was a problem. We know it happened again, and therefore we know it's likely to happen again. And we would like as much as possible to avert that with the team. And we would very much like to assess this case and plan better for the future. What lessons? So we need SOPs on how to manage our babies who have, our mothers who have had this history, and our babies who have signs of hemolytic anemias. We don't have that in our setup. We need to move to a place where we have awareness, we can recognize, and every member of the team knows exactly what to do. We don't have one person who thinks ahead and three others who pull them back in the decision-making and action. So we need to work on that. Next slide, please. We need to create awareness to improve responsiveness in our hospital, both in hospital and out of hospital. Our first case was very successful because there are people who came on board and moved mountains to make sure this baby got the blood when he needed the blood. There was a whole RH negative foundation that the chairman made sure if we needed blood, he dispatched a donor. Can we normalize this, and make it part of practice? Or is it a one-off success story that we will soon forget? And we need our multidisciplinary teams. Yeah, so thank you very much. I'll stop there. And I would like to invite any questions before I hand it over to.
Okay, I have a lot of questions. Did you test the cord blood for bilirubin levels?
Yes, That was the intention. As I indicated, that was one of the mislabeled samples.
It was
So they
missed.
ran a UEC instead of a bilirubin. So we never got to know what
Okay.
the bilirubin was on the cord blood.
Wow.
And we didn't realize this until the results came back in. And that's when we realized, so that was an omission.
Yes. Okay. My other main question is, was the direct Coombs test done after the exchange transfusion?
It was before, although
Okay.
it was outsourced. So we did not get the results soon enough, but it
Okay.
was done before.
Okay.
It was actually part of the initial samples that were taken, but the hospital could not run it. So it's
Okay.
until the following day that they sent it out, and yeah.
Okay. Thank you.
Maybe we take just one question and then we move on to our keynote speaker.
Thank you, Dr. for that enlightening presentation. I come from the lab, specifically hematology lab and BTU. And such such outcomes actually help us improve our services. And I would like you to confirm for us, was this patient in KNH?
No, from the beginning I said, sorry, you must have missed that. I said that this was a different hospital.
But still, yeah.
But
okay.
that is actually what happens in a lot of hospitals around us.
Yeah.
So, and that's why I felt the need to highlight this, because how many patients actually get managed under the ideal conditions.
Okay.
So this was a different hospital.
Thank you for the clarification. But still, some of those the negative aspect of this presentation could happen as well.
Yes.
There are some things that are beyond us, like availability of blood and blood products, specifically the right products for these cases. Leukoreduced, irradiated, that we may not have. Though we have tried to establish the critical values, which we try to communicate, but as we go along, we notice that there is much more we would like to communicate. And it is important to have a direct communication between the lab and the clinical areas. And okay, I needed that clarification, but we have learned from them. Thank you.
Thank you.
Dr. Makori heads the blood transfusion unit in Kenyatta. She needed to clarify so that she can clean her house, just in case it's happening there. So in the interest of time, colleagues, let's move to our keynote speaker, Professor Kenneth Moyes. So as an introduction, Professor is a professor in medical school, Dell Medical School. He's a professor in maternal and fetal medicine with over 30 years experience in hemolytic disease of the fetus and the newborn. He's equally world-renowned for invaluable contribution in fetal treatment, especially in Rhesus disease, including use of MCA-PSV in determination of fetal anemia and the cell-free DNA in determining the Rhesus status of a baby. He'll shed a light on ongoing novel research in this field as well. Welcome, Professor. And then shed some light also on the case we've just discussed and how to proceed antenatally when this lady comes back again. Thank you.
Well, thank you. And I appreciate the opportunity to come across the waters to talk to you today about a disease I've spent most of my career on. One comment about your last case, I think that baby fits the criteria, from my experience, is very rare of gestational alloimmune liver disease. But if that's true, my question I wanted to make to the speaker was, what are you going to do in the next pregnancy? Because the only treatment for that disease is IVIG throughout the next pregnancy. And with that treatment, the success rates for good outcomes in the baby are like 90%. So unfortunately, you didn't have all the diagnostic criteria there, including a gingival biopsy, looking for iron stores or iron. But I think there's enough data there to consider that diagnosis and consider treating her if you can get it qualified with IVIG next pregnancy. I'm going to talk to you about Rh disease today and disease in general related to alloimmunization to red cells. This is a paper that's yet to be published. We just submitted to one of our major meetings looking at 9 million US pregnancies between 2010, 2021. And despite widespread use of Rhesus immune globulin, we still see 1.5% of all pregnancies in the United States have some level of antibody. And here you can see D, E, K, and little c are all still present in blood testing done at a commercial lab on first time at the early part of pregnancy in 9 million pregnancies. So we're going to see red cell disease continue no matter how good the prophylaxis program is in any country. Likewise, this is data from codes, neonatal codes at diagnosis, at discharge, and looking at the different types of hemolytic disease in the newborn. The first blue bars at the top indicate the RH disease falling over time in the nursery diagnosis. So HDFN in nursery diagnosis. The ABO is pretty stable, and you can see other, which is KEL and other antibodies are pretty stable also. So we are seeing, at least in neonatal diagnosis in this time period of 500,000 pregnancies in the US, the disease is getting more uncommon, if you would. However, if you look worldwide, this has not gone away. There are over 52,000 stillbirths that still occur in the world annually, and 114,000 neonatal deaths, usually from connectorus, the majority of these. And of those survivors, many of them have long-term neurologic deficits based on surviving connectorus. So that this is not a minor problem worldwide, in that babies are still dying from this disease, both in utero and after birth. And those that do survive can have connectorus because of high bilirubin problems. And just to talk a little bit about Rhesus immune globulin, because it has been one of the successes of perinatal medicine in the 60s and 70s. However, if you look at how it's used throughout the world, you notice that if you look at the doses given, both antenatally and postpartum, doses needed to be given, only about half the women in the world who need Rhesus immune globulin actually get it. And if you look in sub-Saharan Africa, you'll see if I can see, that you should be giving about 2.5 million doses, and only 110,000 doses are given in sub-Saharan Africa. So there's a big deficit in who can get this medication and who actually gets it for a variety of reasons. And just to show you, this is the gap, and I localized your country here. You fall into the 80% range of 80% of patients who could get it, where it's indicated don't actually get it. So this is a preventable disease, at least for the Rhesus antigen, if the prophylaxis can be given. In the US, there's still cases of antenatal sensitization. That's about 2/3 of them. 13% of people just forget to give it. Even in our country, where we have standard protocols, people forget to give Rhesus immune globulin when it's indicated. Our standard, this follows the ACOG standard, is to do an antibody screen at the first prenatal visit. At 28 weeks, we repeat the antibody screen because there is a rare patient who gets sensitized between the start of pregnancy and 7 months. And you would miss that patient by just giving her Rhesus immune globulin at 28 weeks and not rechecking for an antibody screen. So that's a protocol in our country that we use in the US. And then again, after delivery, patient gets a drug. The drug is good for up to 72 hours. The story of where that comes from is fairly fascinating. It relates to prison experiments done at the Sing Sing prison in upstate New York, where the fathers of Rogam, if you would, gave blood to the prisoners on Friday, and the warden would not let them back in until Monday. And that 72-hour window seemed to work, and that's where everybody comes up with 72 hours. Not very scientific. It may work up to 13 days, and some people feel that even if you miss it, you should give it out to 28 days. We really don't know what the mechanism of Rhesus immune globulin works, but what we do know is once you are sensitized, given it again, and I've been asked this question a lot, doesn't help. So once you are sensitized, the prophylaxis no longer is effective. The standard dose is 300 micrograms, will cover a 30 cc bleed, but in about 3 out of 100 or 3 out of 1,000 pregnancies, that will be bigger than a 30 cc bleed. So you need to give more than one dose. And so our college, American College of OBGYN, American Association of Blood Banks, recommends we do routine blood testing of all Rh negative women. When they deliver, we do what's called a Rosette test, which is a screening test, and it's read as yes or no. And if it's no, you give 1 unit. If it's yes, you have to go on to do either a Klahr-Becky stain or a flow cytometry stain to calculate in consultation with the blood bank the number of vials to give to be effective in preventing prophylaxis. There's actually some old data that if you don't give enough antibody, you can enhance the chance to develop true antibodies from the patient. So you want to give an excess amount. And if the Rosette test is positive, you can move to the KB and calculate the dose. You'll see you give actually extra dosing here to be sure you give an exogenous extra amount of RhoGAM in these cases. And then we give Rhesus prophylaxis for other issues, like any invasive prenatal diagnosis or blunt trauma to the abdomen, or cases of antenatal hemorrhage. And the answer is, if in doubt, give Rhesus immune globulin. There's no harm to giving it, but obviously once you're sensitized, it doesn't work. I pulled 2 papers for you because I understand in your country that number 1, or maybe even the only Rhesus immune globulin available, is something called mono-Rho, which comes out of India. It comes from hyperimmunized donor that's moved to hamster ovarian cell lines. So it's a synthetic, a biosynthetic, if you would. This is a very small study that was done randomizing patients between this particular preparation and RhoGAM at 10 hospitals. It was given postpartum in a standard dose, and then titers were done, or screens were done at 90 and 180 days. And it wasn't a very good trial. There were not very many patients in it. And there were 21 patients lost to follow-up at 90 days, and 19 lost to follow-up at 180 days. When they did the math, there was no statistical difference in the rate of sensitization, but I think all the folks in this field feel that this was not an adequate clinical trial to say that this particular preparation is as good as polyclonal RhoGAM, and more data is needed before it's widely used as a replacement for Rhesus immune globulin that's polyclonal, which is RhoGAM. This is just another study just published late last year looking at the side effects of mono-Rho, which actually turned out to be fairly minimal. There were 19 treatment effects related to pain at injection site, but at least from a safety point of view, it looked pretty good. So safety okay for mono-Rho, but efficacy still to be questioned as the best drug to use to prevent this disease. Now, I'm going to switch gears for a second from prophylaxis to treatment. I'm talking about our toolbox and what kind of new tools we have today to take care of this disease. The first are gel antibody titers. We used to do titers by tube. So once your antibody screen was positive, you then have to identify the particular antibody and then titer it to tell us how much you have. And now we have automated technology called gel technology that can run on a machine, so the tech doesn't have to do it themselves. And this is done quite in a widespread fashion in the States. The problem is gel picks up more anti-E's, and some of those are naturally occurring, and more anti-M's, which are IgMs and don't usually cause disease. So I get lots of calls about E's and M's that really don't amount to much with new gel screening technology done on blood samples. The other problem with this is that the titer in a gel is much more sensitive, i.e. it's a much higher level that comes back compared to a tube titer. And if you look at this box here, you'll see that if you had a tube titer of 16, in 2 of the cases, the gel titer came back at 256, and in one case, 1,024. So it's very difficult to determine what a critical titer for an antibody is using gel. And in essence, the take-home message is it's much higher than a tube titer, and tube titers are what we've always used to determine clinical efficacy and clinical concern for the fetus. The antibodies to worry about that I always preach are D, Kel, and C. Those are the bad players. So we all know Rhesus D. Kel is the second most common. This is a series of patients transfused in Leiden, the Netherlands. That's the one referral center for the whole country. Little c can be just as bad as D, and then you have rare cases of big E, little e, and FYA. But if you only have to take home D, Kel, and little c, those are the bad players during pregnancy. Now, there's been a big change throughout the world in determining the baby's blood type. And we know that about half of individuals are heterozygous for the Rh gene. That means half their babies won't be Rh positive, they'll be Rh negative and unaffected by mom's antibodies. So we always start with checking dad's blood type, and then you can do DNA testing, as I'll show you here, to determine what dad's antigenicity is, whether he's heterozygous or homozygous. For D, you have to do genotyping. For all the other antibodies, you don't need to genotype. But here's, in essence, a negative dad, and you see no spikes in the RHD exon 5 and 7. And then if you look at a heterozygous dad, you see one spike. But if you look to the far right, you'll notice the spikes are half the size of an internal control RHC gene, which we all have. And then if you look at a homozygous dad, you see taller spikes, and the ratios are the same as the internal CE gene. Therefore, he's got 2 copies of D. So the bottom line here is that if you have to determine dad's zygosity for D, you use genotyping with this quantitative PCR to determine dad's zygosity. For the other antigens, as I mentioned, you can use serology with the blood bank. You don't have to do genotyping. 8% of individuals are Kel positive. So the majority of partners, if someone comes in with a Kel antibody on their antibody screen in pregnancy, the majority of their partners are Kel negative, not all of them. But you can do testing with serology and determine if dad's homozygous or heterozygous, which would determine, does the baby always going to be affected or only partially affected half the time? Now, the new paradigm on this that's now capturing the world is free DNA. Now, we know free DNA comes from the placenta. It's from placental apoptosis. It's a small percentage of the floating DNA in the maternal bloodstream, but it increases in the amount over time, and it seems to go away pretty quick after the placenta is removed. So once the placenta is delivered within a very short time, there's no DNA left. So why is that important? Well, you don't want DNA to float around from the previous pregnancy. So in the next pregnancy, you can rely on the fact that that DNA you pick up on is from the new pregnancy and not from the previous pregnancy. It's been around for a while. 1993, some time ago, Dennis Lowe at Oxford described 3 cases of determining the baby's RHD type with is fetal, but there's enough there to find it. And this is just the assay that's now available in the United States, not only for D, but also for E, little c, Kel, and FYA. So using these primers, at least in the US now, there is an assay available on a simple blood test from the mother at 10 to 12 weeks. We can determine if the baby's antigen positive or not. And if we look at their validation studies, they actually look pretty good. This is 1,000 samples validated, 600 where they found the patients, the fetus to be negative, 400 that were positive. So they were 100% accurate in these 1,000 samples that they checked to show that their assay is working. And their assay is now widely available in the US, as it is in many other countries, and is sort of part of the workup now for determining, is a pregnancy at risk? Once there's an antibody present, once there's a titer that's significant, does the fetus carry the antigen? Now remember, 38% because of genotyping and some dads being heterozygous, only 30% of Rh negative women will carry a positive baby and need antenatal rhesus immune globulin. And so now in more and more countries, it's becoming routine, even in unsensitized pregnancies, to do free DNA. And if the baby turns out to be Rh negative, don't even give rhesus immune globulin at 28 weeks. And talking to my friends in the Netherlands, they don't even type the baby at delivery. They don't do cord serology. They trust their test. And if mom's been tested during pregnancy and she carries a negative baby, that's the end of the story. They don't get any more rhesus immune globulin. England's now using the test, and Canada's considering using it in this way. Currently in the US, we do not do free DNA to determine whether we need to give ROGAM or not. Now, the next big thing that happened in our field was the advent of the middle cerebral artery Doppler. Here's a copy of the paper from 2000 when Giancarlo first worked with us in Houston and developed this assay. Subsequent study by Dick Opkus in Leiden showed it worked in a larger population. And then I wrote this editorial for the New England Journal back in 2006 that said we should put the needles away. For those who are old enough, we used to do amniotic fluid assessment of bilirubin to check for a sick baby. That all went away and is sort of historical with the advent of MCA Doppler. There are a couple of tricks to Doppler, and this is the key. I always like to talk about the cop that likes to get to write the biggest ticket. If you drive by on a side street and he hits you with his radar, the angle of incidence is 90 degrees and the cosine of 90 degrees is 0. So his radar reads 0 on his radar. He thinks you're speeding because he saw you go by. So he now gets behind you in his car and travels behind you for a while. And now the angle of incidence is 0 and the cosine of 0 is 1. So it's your true speed. And that's what he's going to write you the ticket for. So even though you thought you were speeding, once he gets behind you, you can accurately detect your true speed and write the biggest ticket. And that's a principle that's really important for when you do the MCA Doppler. You have to have a 0 degree angle. And when you shoot down the barrel of the MCA to get the true velocity, it's the only Doppler in the fetus that we ever measure where we're looking at velocity and not things like SD ratio or pulsatility index, which are ratios. So you have to be accurate and get a 0 degree angle so that you get the true velocity. The other thing is you have to be in the proximal part where this arrow is in the MCA. You can't be way far out on the end of it because the velocity decreases as you get further away from the heart. And so what you see here is the arrow pointing to the proximal portion of the MCA, which is the key part to begin to measure. Also, when you look at the waveform, there's some things you can do to get the best measurement. You have to change some buttons on the machine, the PRF and the baseline, so that the MCA takes up the whole field. So you get a nice big picture of it. You want to colorize the image so you can see it much better than black and white. And then you want to use manual calibers to get the very top of what I call the candle, which is the very fastest blood vessel or blood vessels that are moving, blood cells that are moving. And so you don't want to use automated software. You use this standardized manual calibers to get that. And the baby can't be breathing and moving when you do an MCA Doppler. It has to be still, or you get numbers all over the place. And I love when people call me up and say, well, the MCA is between 1.3 and 1.8. Well, it can't be. It's got to be a real number somewhere in between those. It means there's other things happening when they're measuring that. It should be standardized. And here's just a picture of a serial set of MCA Dopplers being measured over time. You can see 3 zones here. And we, as mentioned earlier, 1.5 is the sort of critical zone. That means the baby has moderate to severe anemia. And here we follow this baby throughout the pregnancy. And finally, when it reached that 1.5 threshold, we did a chorecentesis, the baby had a hematocrit of 26%. How do we pull these tools together? So with early disease, and particularly in first pregnancies, we follow mom's titers every 2 to 4 weeks. We use 16 as a critical value to be worried about the baby for most antibodies. At our particular institution, and I think most major institutions, although this has been argued by some, we use a critical titer of 4 for KEL. We determine dad's blood type, and if there's a possibility of the baby being antigen negative, we use free DNA testing to see does this baby carry the antigen or not, and could it be affected? If dad's heterozygous, as I mentioned, we do free DNA testing. We can do amniocentesis, but that has fallen by the wayside as we bring in free DNA testing more. Dad's homozygous, we know the baby's effective, and then we need to start MCA Dopplers as early as 16 weeks. Now, there's a lot of argument about how often to do these. My preference is to go weekly. If I get a couple of values that are totally normal after 3 weeks, I might stretch them out to every 2 weeks. But I think it's important to start every week when you do these. And if the value goes over 1.5 multiples of the median, that's when the baby could be sick and you move to cortocentesis. And if it's below 1.5, you just keep doing those until you hit 38 weeks and then you bail out. We've heard earlier that titers aren't helpful when you have a history of a previous loss, and that's true. But the bottom line is you still should do a titer. There are some things that make you decide, some management issues that may come up with the titer. For instance, if I had a titer this high, I might offer the patient a different therapy. In addition to that, I might never change the MCAs to Q2 weeks. I might do them every week. And again, in the subsequent pregnancies, we start MCAs a little bit earlier at 15 weeks, and we do them every week. And we're looking for a value of 1.5 or more. So this is the whole algorithm here. You can follow it. I did give a copy of the slides so you can see it. But basically, it's, as we mentioned, once you have a positive antibody, you're going to check titers, you're going to check dad's blood type, and you're going to go to free DNA at 10 to 12 weeks. If the baby's positive and you hit a critical value, MCA Doppler start as early as 16 weeks. Repeat them every 1 to 2 weeks, looking for a value of 1.5 or higher. Now, transfusion, this is still the life-saving blood of these babies and has been introduced since 1963, but we still do it today and it still works. How do you time your transfusions is always some contesting about that. I happen to use empiric intervals. Some places use sort of a predicted fall in hemoglobin between transfusions to decide. Some use MCA Doppler again to see, to wait for it to go back up again to do the next transfusion. There've been some studies to show, as you see here, that it's not as good as intervals. So the receiver operating curves are not as tight as just using set intervals. So what you see to the right here is what we do at our center, and it seems to work and has worked for many, many years as to how we decide when to do the next one. One take-home message is if the baby is extremely anemic, under 24 weeks, you can't fix the hematocrit in one setting. It makes sense. You're trying to make this baby's physiology change from pumping Kool-Aid to pumping molasses. And so if you don't want to increase the hematocrit over 4-fold or 25%, and you come back in 2 days and do it again, and then you could take the baby up to the normal value. Putting blood in the peritoneal cavity, if the baby has ascites, doesn't work. The blood just sits there. And know that if the baby's hydropic, it will get better, but the placenta will be the last part to resolve and become normal again. And we talked a little bit today in some of our meetings about blood. We actually do an extended cross match to the mother. So we just don't type her for ABO and RH. We look for a bunch of different types of antigens and try to get the best blood to do the transfusion. The reason for that is we can prevent the formation of new maternal antibodies. We like fresh blood if you can get it less than 3 days old, CMV negative, leuko reduced, means you take the white cells out and you irradiate the blood to kill any white cells that are left to prevent graft versus host reaction in the baby. And then we pack it to 75-80%. There was a question earlier about how much blood you give. I had a smart fellow one time say, gee, if you just figure out the weight of the baby in grams and multiply by 0.02, that's how much blood it's going to take to raise the hematocrit 10 points. I know, so that can't be, that's too simple. And lo and behold, it's true. As long as your donor blood is in the high 70% hematocrit range, this formula works every time. We write it on the whiteboard in the OR, and we know exactly how much blood to give without any fancy computers or anything. Some other tricks to the trade. Floating cords are a no-no. If you go after a floating cord, you have about a 2-fold increased risk of complications of the pregnancy. We try to either target the umbilical vein at the cord insertion, or the Europeans, and we've begun to use it more and more, use it inside the liver of the fetus. So you actually enter the fetus itself and go into the intrahepatic part of the umbilical vein. And you want to stay away from the umbilical artery. All the neonatologists know if you touch the umbilical artery, it spasms. So that's associated with a 10-fold increase in complications. All of our babies are temporarily paralyzed with vecuronium. That's been associated with an 80% reduction in complications because the baby's not moving during the procedures. We like to check a hemoglobin electrophoresis on our final sample, because that can tell us that when we've totally replaced that baby with adult blood, donor blood, we can stretch out the intervals. And my rule for needle size is a 22 gauge under 22 weeks and 20 gauge over that. We've always been a proponent of a combined procedure. So we do the IVT and then we put some blood in the belly as well to get a more stable hematocrit between procedures. And we have used IPT, and this is now my second case I'm currently doing as we speak. You can do intraperitoneal transfusions as early as 15 weeks. So you can't hit the cord at 15 weeks. It's just too small, but you can put blood in the peritoneal cavity, small amounts, and bridge it till you can get to a point in pregnancy where you can put blood in the cord. And this is, I'm now managing my second pregnancy like this with transfusions starting as early as 15 weeks quite successfully. So when you see the video, you always pick the best video. This is one from some time ago. You see the needle entering on the right as it comes through the placenta to the umbilical cord. We always grab a sample of blood. We are lucky enough to have a machine right outside the room to measure that baby's hematocrit. We put the vecuronium in to stop the baby from moving, and then we start the infusion of cells. And you should always, one of my caveats is we should always see cells coming down the cord through the umbilical vein to know that we're in the right place and the baby's getting the blood. Our last procedure is at 35 weeks. We give mom some phenobarbital. Not everybody does that, but that seems to rev up the fetal liver so that the baby conjugates better after delivery. And we haven't done an exchange transfusion in a baby in probably over 5 years because we deliver these patients late at 37 to 38 weeks after their last transfusion. At 35 weeks, if these babies are looking okay, we can induce them vaginally. There's no reason to definitely do a section. When you look at the data on how well the big centers do, this is data from the Leiden group, you can see that they've gotten really good at doing transfusions. So in their hands, and there's only 4 docs there that do the procedure, and they do, like I said, the procedures for the whole country of the Netherlands, they have a 97% survival rate between 2001 and 2015. Now, that's not the case throughout the world, and we have a lot of docs who are starting to do procedures, or they do very few procedures, and they're never going to have those kind of numbers. But that's what you're shooting for as to the best outcome with transfusions. The other thing we sometimes miss, and I worry a little bit about this baby going home, is top-up transfusion need. These babies are suppressed. Their bone marrow is going to sleep. When you check their DAT at delivery, it's negative. The babies come out negative because they're all donor cells. And even without IUTs, some of these babies need top-up transfusions at 3 to 4 weeks of age. If you follow them weekly, about 97% of these top-up transfusions occur before 45 days. So take home, once you transfuse babies, you're not done with them. They have to be followed by a good pediatrician or a pediatric hematologist weekly for up to 6 weeks. And many of them will need a top-up transfusion. They'll bottom out again, and you have to get some blood in the baby or to become very sick. Eventually, they'll start making their own cells again and convert to their blood type and be fine after that and have a normal outcome. So just the top-ups are 15 mils per kg and given fairly slowly. And these are some thresholds that have been suggested with no good evidence, but a hemoglobin of about 7, 3 weeks out, or a hematocrit of 21 would warrant the baby coming in for a top-up transfusion. And finally, as far as long-term outcomes, the only study out there is the Lotus trial, again, done out of the Netherlands, looking at the outcomes in these kiddos. And basically what they found is that the incidence of CP was a little bit higher than the general population. But interestingly enough, bilateral deafness occurred in 1% of these children, could be related to high bilirubin levels. I always ask the moms to get their children's hearing tested at a year of age. In the US, everybody gets tested at birth by law. Every baby is tested for deafness, but I recommend they get tested again at a year of age. And if you look at that study, the things that drop out is if the baby's hydropic, or if the baby's born prematurely, or has some other severe neonatal morbidity, those are the babies that have more neurologic deficit later on. So those are some things that can be used in counseling to suggest perfect outcome versus a compromised outcome neurologically. Now, I'm just going to briefly mention that there is a new treatment coming. We're actually working on this right now. The Johnson & Johnson company has developed an antibody, a recombinant antibody called nipocalimab. And basically, if IgG, this shows you IgG connecting to the normal FcRn receptor. That's the neonatal Fc receptor that's responsible for transferring IgG across the placenta. And what has been developed is a new antibody. In this case, it's M281 or nipocalimab that blocks the Fc receptor. So it actually keeps the antibody from crossing the placenta to the fetus. And it works in two ways. First of all, that same receptor salvages your IgG in your bloodstream and returns it back to the bloodstream. So when you block it, as you see here, that little red antibody attached to the blue Fc receptors blocked it. So now the antibody doesn't get salvaged and returned to circulation. In fact, it gets pushed over to be degraded inside the cell. Bottom line is mom's titer drops. Her total IgG drops, but her titer also drops with this treatment. And on the right, you see similarly the IgG, this nipocalimab binds to the FcRn receptor and prevents the antibody from crossing the placenta. So this is probably the future of the treatment for this disease. Won't be with surgical treatment through intrauterine transfusions, but in fact be with this drug. And this is the phase 2 trial data that has been released. The other data has been submitted for publication to show that in a group of very high-risk patients, these are women that lost their babies in a previous pregnancy, more than half of them got to 32 weeks with no transfusions whatsoever. And so the phase 3 trial is starting in the US and actually worldwide to begin to see if this drug really works to get it to market. So I show this picture as a schematic of how we do IUTs. It's pretty archaic if you think about it. We simply put blood into a baby that's normal, just happens to be the wrong blood type, until it gets old enough to take it out of that hostile maternal environment. And it's really kind of sad that we haven't come up with a better way to do this until recently, but that's the bottom line. But I hope one day I'm still not up here talking about transfusions and we're talking about medical treatment of this disease and this disease goes away. But thank you very much for having me today. Happy to take some questions.
Do we have any questions?
Thank you very much, Professor Moise. That's very insightful. It's interesting that while we are trying to scale up use of in utero transfusion, you're walking away from it. But nonetheless,
Somebody asked me how long it'll be before that drug might be available, and it's going to be several years before we ever get it through the trials and finish. But even then, I think there will be people who come late. The drug works better if you started at 14 to 15 weeks when the antibody's starting to cross. So I think people with poor prenatal care will come in with high drops and not be a good candidate for the drug. So I don't think transfusions will ever go away completely. And as you know, we use transfusions for parvovirus and other diseases. So I think there's still a need to do those. I think it'll just be a lesser need in the people that are picked up antenatally at a reasonable time.
okay, so my question is, in view of the pathophysiology where we are doing in utero transfusion and, as you correctly put it, suppressing erythropoiesis for pretty much of the pregnancy, the practice at your center, have you tried something like erythropoietin, and has it had any benefit in terms of raising the hemoglobin levels of this baby's postpartum and reducing the need for top-up transfusions?
So you're talking about in utero use of erythropoietin or postpartum?
Postpartum. Is
Yeah,
it
so
something that's...
Yeah, there's been a lot of interest in giving the babies erythropoietin to prevent the need for these top-up transfusions. And I know there's a trial, a randomized trial about to be published again out of Leiden to suggest it does work. And so I think it's going to become a standard to administer erythropoietin. They use a preparation that's given once weekly and find that the babies need fewer and fewer, if any, transfusions, so that the bone marrow recovers faster with erythropoietin. What I did notice in one of the presentations, the baby went home on iron. None of these babies need iron. If you transfuse them in utero, they're loaded with iron. You check their ferritin levels and they're off the charts. So we never give iron to our babies that go home. They don't need it. They're going to retic on their own once their bone marrow wakes back up. Erythropoietin makes sense. Folate makes sense, but they really don't need iron therapy. They have plenty of iron on board to make red cells.
Yes, good afternoon. Thank you for a very good presentation. Just a question. There's an ongoing study now in most of these mothers who are sensitized. There's this study which is ongoing whereby Giancarlo are also involved. I don't know whether you've got any experience or if your center is also involved, whereby you're giving medication for those mothers who have got high ICT levels so that they can be able to push them to at least beyond 23 weeks onwards, whereby you can now be able to give, to do exchange transfusion. I don't know whether your center is involved in this study, and if so, do you have any experience with it?
Yeah, so if your question is related to the use of IVIG during pregnancy, there are some case series. There's no good randomized trial, but there are case series that suggest that IVIG started early enough does prevent the early onset of the need for transfusions. You might gain 4 to 5 weeks if you compare it to the previous pregnancy. So if you started early enough, let's say the patient had a transfusion at 20 weeks, and you started at 12 or 13 weeks in the next pregnancy, you may get her up to 24 weeks before you do a transfusion. So we do talk to our patients that have had early onset disease about treating with IVIG. Some centers, including mine, use plasmapheresis with the IVIG to drop the titer and then give the IVIG. And you buy time, not in every case, but in some cases, you buy an average of about 4 weeks before they need a transfusion. I have had patients that I put on that protocol who never got a transfusion in the next pregnancy. I don't know why. So we don't totally understand the immune system, but it is effective. I believe it's effective in the patient with really bad disease to buy time, knowing you're going to end up doing a transfusion anyway, but you're going to do it much later with a much higher technical success rate.
I have a question on the use of prednisolone in pregnancy. Now that
Yeah,
IVIG.
I saw the baby was starting pernicious. I don't know of any data anymore that steroids given antenatally make a difference in the baby's outcome. I understand the rationale might be to suppress the maternal immune system a little bit, but I don't know of any data throughout the years where oral steroids to the mother prevent disease in the baby. IVIG works a whole different way. We think IVIG probably blocks the placenta to some extent, but we don't have any data that steroids given antenatally make any difference in outcome of the baby.
Thank you for your presentation. Just a query. When we have mothers with the weak D antigen, unable to confirm the true D status because of finances, what is your thoughts on still giving anti-D?
Yeah, my favorite question, weak D. Weak D used to be called DU. It's no longer called DU. It's called weak D. And there are two types. One type of weak D expresses fewer intact antigens on the cell. The other type of weak D is what's called an RH variant. And there are antigens on the cell, but they're not totally intact. They're missing parts of them. In the first case where you have the intact antigen, but fewer numbers, those patients still need Rhesus. Those patients are not going to get sensitized, right? Because they have the intact antigen. The second case where you have the antigens, but they're missing a piece of the antigen, they can get sensitized. The average OBGYN gets very confused about all this. So the latest recommendations in the US from ACOG is treat them all as RH negative patients and give them Rhesus immunoglobulin. And err on the side of, because you're not going to hurt the patient, but you're not going to have to distinguish between the two types of weak D. There's a genetic way to tell the difference between the two types, but most centers don't have access to that, and it's expensive. So it's easier to say, if you get a weak D result back, Just give Rhesus immune globulin like you normally would, and then don't worry about it, because you're not going to hurt the patient, but you're going to protect those patients that have that weird variant that's difficult to determine. It's a good question, though. Yes, ma'am.
Thank you for the presentation, Professor. As the resident who followed up the patient I presented, I was very discouraged when the MCA PSV peaked to almost 87.
Placenta, from what I saw of your video, when you go through the placenta, you cause an amnestic response to the maternal immune system. Their titers go up dramatically. And we have seen those babies drop out much quicker because you just create more maternal antibody to cross. And we actually have some data to say that you almost always get an increase in titer when you go through the placenta. So it may have accounted for why you dropped it out so quickly. And I use that. I will check a titer after I do that. And if it's gone up dramatically, I'm going to be watching that baby a lot more carefully to see when I need to go back in. And that may be where the MCA helps you decide, gee, I was going to wait 3 weeks. Now I'm going to go 2 weeks. I was curious, so why you all delivered the baby one day after the second transfusion when it was successful? Why wouldn't you just, if you did what you thought you did, why don't you just wait? Again, if you look at our data, you're going to get an exchange at 34 weeks because the liver's not mature. But at 37 weeks, the baby's less likely to need an exchange, have respiratory distress syndrome, all the things that premature baby had.
That was actually going to be my second question. Could we have gone beyond maybe
Yeah,
an
if you
early term?
if you took that baby up to 40, I would have waited at least 2 weeks to deliver that baby. Was it 1 week? I thought it was 1 day. Okay. It was 34 and 1. Okay, that's better. Yeah. Because at 34 and then deliver at 34 and 1, I went, yeah, unless the baby was showing signs of distress. But I think the days of, I remember delivering all the babies at 32 weeks. No one would ever do a transfusion after 32 weeks. And even when I was at Kipros's course in Spain in June, he was astonished that we delivered babies at 38 weeks. And what I said to him is, none of my babies get exchanges because their livers are mature. The phenobar probably helps when I give it to the mother, but the babies all come out, they breathe okay, they go home with their moms. And that's been a change in our pattern. We'll do an IUT at 35 weeks. Now we do ours in the operating room. If there's ever a problem, we can bail out and do an emergency C-section, probably 5% risk. But our goal is to get the mom to 38 weeks at all cost. And we see much different neonatal outcomes in those babies. They just handle their bilirubin so much better. As you know, an exchange transfusion is not without risk in a baby. I mean, there are lots of electrolyte and sepsis issues and lots of other issues that I'd rather not do an exchange if we can prevent it in a baby. And the womb's the best place to do a transfusion, not outside. Yes, sir.
Yes, another comment. We know RH burden is an issue. And earlier on, before the advent of us having opportunities and skills of being able to do things like exchange transfusion, I've been looking after a number of these mothers. And some of these mothers would come early gestation, very high ICT levels. I'm just picking from the comment you had made. I used to start them on low-dose steroid, and I would end up bringing ICTs of 1 in 26 down to below 1 in 60, 1 in 64, 1 in 32. And these mothers would go on until about the cutoff was about 35 weeks and deliver them, and they have their babies. So it would be good still to, I know the Netherlands used to do that sometimes back, use of steroids, if I'm not wrong. And I know in Europe now and America is not something which is being used because you have got better aspects of treatment. But I used to use that, and I've had good success with it. But we need now to reevaluate further what exactly was the mode of action and how was it, were we able to reduce complement fixation so that these mother sensitization levels go down. But it has given me some reasonable success. Yeah, not in all, but majority.
Yeah,
of
yeah,
them,
I would
yeah.
defer to your experience because I just don't have any experience with the antenatal steroids for this disease. There's some old studies that even suggested high dose Phenergan had some beneficial effect in these pregnancies, but I don't think any of those have been confirmed in larger series, but I just don't have any experience with steroids. I do know that we see patients with titers, and the same titer in one patient doesn't mean the same thing in the next patient. So you may have a third to the antibody and how the antibody crosses the placenta. We have never really studied that very well. We're undertaking that study with the Sanguine lab as we speak. So different antibodies cross differently. And so the same titer in one patient isn't the same as another. So it's difficult to do those studies because if you just treat by titer, you're still going to have a large population to see a difference based on the drug. But I would defer to your anecdotal experience. I just don't have any experience using steroids to treat this disease. Pastor Tim was going to ask me a question. I was in trouble. I know if you fall asleep, you're playing for me. I know that. He's jet lagged. He got in at 2 a.m. yesterday. So, yes.
Thank you again. Just maybe a comment. If you have a HIV patients who are Rhesus negative, and are they still candidates for intrauterine transfusion, and how do you go about it?
So I didn't understand the question. Repeat it for me.
When you have a HIV patient and you for Rhesus who is not Rhesus sensitized, and you confirm they are candidates for transfusion, how do you go?
Like an
HIV
HIV
positive
patient. Is
mom.
that what you're asking? Oh, goodness.
Yeah.
Thank goodness I've never had to face that. I think you're in a risk benefit ratio of trying to decide, is the baby going to die from its disease? Are you going to infect that baby with HIV? I think we have such good treatments for HIV. As long as I counsel that patient that we had a better chance of instilling the virus into the cord, then it's probably we can treat that, but we can't treat anemia and death that occurs in utero. Would I maybe deliver that patient prematurely versus doing multiple transfusions? Yes, but I think that would be a difficult situation and require some counseling. People have asked me that question before, and I don't know of any case report. You'd think somebody would have reported it by now, where HIV infection occurred in the baby, the fetus, so the baby subsequently because of IUTs. There's pretty good data on amniocentesis to say that doing an amnio is different than the cortocentesis, right, where you're going directly into the circulation. But there's pretty good data on both HIV and hepatitis that amniocentesis doesn't result in fetal infection. And so we do that in those patients all the time, even though you see maternal blood, streaming into the amniotic cavity after those procedures. And the baby swallows those cells probably. Different from injecting cells directly into the fetus, though. That could have a potential of infecting the fetus. Yep. Well, thanks for having me today. I appreciate the questions and look forward to working with your group and getting your IUT off the ground. So take care now.
Thank you very much. Hello. Oh, thank you very much, Professor Moyes, for this very insightful lecture. I think we are past our time, about 17 minutes. I would ask my professor here to do our closing remarks, and then we can call it a day.
Oh, you're ambushing me. Thank you, Professor Byers, for a very good presentation and discussion on a very, very important topic, which has actually been one of the, what I call a neglected condition, because it's basically lower and lower middle income countries' problems. Your coming in and your interaction with us here just helps us to be able to help tone up our levels of interaction with our patients, and also opens up a level of cooperation and collaboration with in terms of having a center of excellence of taking care of the isoimmunized mothers in this region. And it had actually been proposed that our unit here in KNH be the center of excellence in the region. And this had been put forward through the auspices of AFOG. There was a big meeting which was held in in May last year in Mombasa, which was also patronized by the AFOG president and some of the representatives from FIGO. And a lot of work is already undergoing. And I'm sure sooner or later we'll start getting more and more specialists from our center here who would be willing to come to your place so that they can be able to acquire the necessary skills. The knowledge they have is just to get the hands-on skills of being able to offer better services to our women and also to the newborns. Thank you, and we appreciate your coming. Enjoy Kenya. I hope you are not running away soon. We have a lot to enjoy. You can be able to enjoy Nairobi, enjoy the rest of Kenya, both day and night. And I'm sure Dr. Chemoi must have prepared some program whereby you can get interaction from most of us. And we are still open. There's enough time if you have more information or more interaction with either the residents or the specialists around, we are welcome. And thank you so much for the day. And thank you for attendance, both those who have attended virtually and also those who have been physically in the room. Thank you and have a nice day.
Thank you. We did not prepare lunch, unfortunately.